Okay, hi everyone, welcome to this evening's Swans University webinar. We'll get started. Just a word of note, we want as much interaction as possible, so at any point throughout the presentation and in the aftermath, send us any questions you've got. To do so on your Zoom panel, you'll see the icons at the bottom. Use the Q&A button, type in your question. You can choose to send it anonymously if you prefer. Come through to us and then following a presentation and in discussion, we'll answer as many questions as we can, as fully as we can. Okay. Those of you that aren't as familiar with Swans University, we are a dual campus university which was founded 100 years ago. We're top 25 in the Guardian University Guide of 2021 and ranked 6th in the UK in the 20 National Student Survey. For sport and exercise science in particular, we're a top 15 UK sports science department. Our research quality in sports science is ranked 9th in the UK per the Times Good University Guide of 2020. And for graduate prospects in sports science, we're ranked 7th in the UK. And on the last assessment, 100% of graduates were in work or further study within 6 months of graduating. So within Swans University, our sport and exercise science research is conducted within the Applied Sports, Technology, Exercise and Medicine Research Centre, what we refer to as ASTEM. And just some of the research groups and projects that we have include work in elite and professional sports, the Welsh Institute of Performance Science, exercise medicine and health, sports ethics, integrity and governance, and the Welsh Institute of Physical Activity, Health and Sport. My name is Adam. I'm from the Faculty of Science and Engineering at Swans University. And for tonight's webinar on how simple inspiratory muscle training may help recovery from long COVID, joined by Dr. Melita McNary, who's an associate professor in sports science at Swans University, specialising in cardiorespiratory fitness, and Dr. Joanne Hudson, who's an associate professor in sports science at Swans University, with an expertise in psychosocial aspects of physical activity and exercise. I'm going to hand over first of all to Dr. McNary, who's going to share screen and begin presentation then. Over to you.
Thank you, Adam. Perfect. Okay, so good evening, everybody, or good morning or good afternoon, depending on where you are. As Adam has introduced, today I'm going to be presenting some of the preliminary findings from this Welsh Government-funded study, where we've been looking at a potential rehabilitation tool for people who are experiencing long COVID. As Adam has said, you've got me doing the majority of the talking, I'm afraid, but after I conclude, we'll be joined by Dr. Hudson and hopefully Professor Lewis, who is a lead clinician at Prince Philip Hospital. I think he's currently being drawn into an emergency, but hopefully he'll join us before we get to the questions. So if you do have any questions, please do put them in the question box so that we can address them at the end. So I guess the logical place to start is with what is long COVID. So long COVID is a term that's now increasingly commonly talked around and is used to refer to the ongoing symptoms of COVID after the acute infection has finished, and those symptoms can be ongoing for weeks or for months. Now, the exact period of time that those symptoms have to have been experienced for to classify as long COVID is actually highly controversial, with the health watchdog suggesting 12 weeks, but anything from 4 weeks commonly referred to in the literature and in the newspapers. But what we do know is that regardless of what the definition of long COVID is, this is a highly prevalent condition. Statistics back in November suggested that 1 in 5 people were likely to still be experiencing symptoms associated with COVID 5 weeks after the acute condition, with that suggested to decrease slightly to 1 in 10, 12 weeks after the acute infection. But as I said, these statistics were released back in November, and we're in a very different situation now, and we've become a lot more aware of long COVID, and a lot of the people who were perhaps in that 5-week group back in November are now still experiencing symptoms. So what we anticipate is that, in fact, it's far more likely that it's nearer 20% of people who are experiencing these symptoms for more than 12 weeks. And what we've come to realize as well is that there doesn't appear to be a strong relationship between the severity with which you experience the acute infection and the extent, the range, and the duration that you subsequently experience symptoms for. And that unpredictability is a very common theme that has come through in a number of our early conversations with people who are experiencing long COVID. So here you can see just a small sample of some of the quotes, some of the anecdotes that people were giving us around their experiences of long COVID. And these were things around they feared to return to activity. They feared the consequences if they were to return to activity. And certainly that the recovery from this disease, this condition, seemed to be taking significantly longer than anyone ever anticipated when we first started to hear about COVID and its effects. Now, the other common theme to the conversations we've had with people with long COVID is the extent to which it's affecting even daily activities. So these are activities like emptying the dishwasher, walking up the stairs, making cups of tea, making dinner, even doing the folding. And these are things that we normally take for granted, but which have become extremely challenging to people with long COVID as they continue to experience this huge array of different symptoms, with the primary symptoms of concern often being those of fatigue and those of shortness of breath. So here you can see some data collected a few months ago, which tried to get an insight into which of the symptoms were most commonly being reported. And you can see right up the top there, we've got fatigue, shortness of breath, joint pain, chest pain, and cough. Now, the one of those that we have focused on is this shortness of breath. And the reason why we're interested in this as respiratory physiologists is that I at least, I should probably say I rather than we, I strongly believe that if we can address this shortness of breath, it's likely to have indirect and direct benefits on many of these other symptoms. And I'm going to try and put an argument across to you now as to why I believe that. So this shortness of breath, this is an endpoint that has multiple components that lead up to it. So the act of breathing is extremely complicated. We take it for granted, we assume that it's something we can do, but it requires the coordinated response of a huge number of different muscles, many of which you can see on the screen in front of you there. Now, we all know about many of these muscles. We know about things like the diaphragm. We've heard about them. We've probably got some idea that it's a fairly important muscle in terms of respiration, but there's also a lot of much smaller muscles which also play a vital role in ensuring an efficient and coordinated respiratory effort. Now, if those muscles, be it the small ones or the big ones, are experiencing fatigue, it's likely to increase the burden on other muscles. And in order for us to breathe in the way that we are meant to, we need all of these muscles to function in the way they are intended to and in the order that they are intended to. So one of our working hypotheses is very much that one of the effects of COVID is potentially that it causes a dysregulation. So perhaps these muscles are all still trying to do what they're meant to do, but they're not necessarily doing it in the right order anymore. And therefore your breath in isn't as efficient or as productive as it should have been, leading to that perception, that experience of shortness of breath. And this shortness of breath, this increased work of breathing is a massive problem. And it is related to other perceptions of symptoms, such as peripheral fatigue. And this was demonstrated in a very nice study done back in 2006, where what they actually tried to do was to see what effect it had if they increased the work of breathing or they decreased it. So we're not going to dwell in this in too much detail, but if I can just get you to look at the graphs on the right-hand side of your screen there, you'll see we've got two sets of bar graphs. Now the first one, if we look on the left-hand bar graphs first, we've got a control condition. So this is natural breathing. They haven't done anything in this situation. The person is just breathing normally. And this is the amount of fatigue that was experienced by their leg muscles. Now, when they took some of that work of breathing away, which is what this unloaded condition demonstrates, you can see that their leg fatigue went down. So when we supplemented the breathing effort, when we meant that they didn't have to necessarily meet all of that demand, then the amount of fatigue experienced by the legs went down. Conversely, if you see the graphs further to the right, when they increased the work of breathing, the perception of fatigue, the experience of fatigue in the leg muscle. So this is what people with long COVID are going to be experiencing with that shortness of breath. They've got an increased cost of breathing, an increased work of breathing, and it's likely therefore to be leading through to negative effects in their peripheral musculature, in their arms, in their legs. This is likely to be contributing to those feelings of exhaustion when you do some small tasks that you would previously have taken for granted. Now, there are some very complicated mechanisms likely to underpin this, and I'm not going to go into those in too much detail today, but I just want to highlight that there is this very clear path whereby this increased work of breathing can lead to that peripheral effect. And this is all via the response of the brain to an increased work of breathing. So when your respiratory muscles are getting tired, when they feel that they don't want to do additional work because they're already reaching their maximal capacity, that sends a signal up to the brain. And in response to that signal sent to the brain initiates a response in the peripheral muscles where what happens is it reduces the amount of oxygen being sent to those muscles. And our muscles can't work if we don't give them enough oxygen. So those muscles will therefore have to reduce the amount of work they're doing, and you will feel significantly increased effort for that amount of work. So that quite nicely fits in with this potential link, as I said at the start, of if we can resolve those symptoms, those experiences of breathlessness, then hopefully it will have knock-on benefits for many of the other symptoms as well. So conventionally, when people experience shortness of breath, as is typical of many chronic respiratory conditions, the typical treatment strategy for them is to engage them in a process of pulmonary rehabilitation. And there is well-established pulmonary rehabilitation programs for chronic respiratory conditions that have a great evidence base for their effectiveness. And these traditional programs typically involve three components, ranging from educational activities to ensure that these patients are familiar, that they understand their diseases, that they understand the importance of healthy lifestyles, including nutrition and exercise, all the way through to giving them coping strategies to enable them to master their condition. But the bit that we're really interested in is that middle bit, as you can imagine. It's that exercise component. And conventionally, the exercise component in a pulmonary rehabilitation program consists of 6 weeks of 3 times a week, 2-hour sessions where people engage in a circuit alternating cardiovascular and strength-based exercises. And as I say, this is an effective program, but there are a number of limitations with this in terms of a COVID world, not least of which is that these are predominantly done in hospitals. And obviously we are not in a time where we want to increase the burden on hospitals. So we need to find things that can be home-based, that can be done safely, remotely, and preferably unsupervised. The type of exercises involved in this type of program don't lend themselves to that environment. They typically involve treadmills or bikes, equipment that we don't have in your average home. So that's one problem with them. The other issue with translating these pulmonary rehabilitation programs to widespread long COVID rehabilitation is that they can be individualized, but widely they are not. And what we've come to realize from our conversations with people with long COVID is that it does need to be a highly individualized approach, and it needs to be an approach that accounts for the good days and the bad days. So when you are feeling better, you could do a little bit more. When you're back on that intensity to ensure that there isn't a consequence to overexertion. And that's really hard to do with a traditional pulmonary rehabilitation program. And that was, again, very much reflected in our early conversations. People highlighted to us that any return to exercise needed to have small progressive steps that were relatively robust against the risk of regression and the consequences of overexertion. And that's very much what we've had in mind when we've been developing the current study. So enough about the background. Let's get on to what we've actually been doing in this study. So our approach to trying to resolve this shortness of breath was to look at respiratory muscle training. So respiratory muscle training is the idea that we can specifically target the breathing muscles. So not target the whole body, but zone in right in on those breathing muscles and train those like you would a peripheral muscle, and thereby elicit a response very similar to what you would see if you were doing strength training, for example. Excuse me. So we would hope that we would see what we call a hypertrophic response. So that's the response whereby your muscles get bigger in size. So if you do loads of bicep curls, your biceps will get really big. Same idea, but for your respiratory muscles. And this is not a new idea. Respiratory muscle training has been around for 3 or 4 decades. Originally, it was probably used more in athlete populations, but increasingly it's being used in chronic respiratory conditions and to good effect, with recent reviews demonstrating that this type of training, respiratory muscle training as a whole, is able to elicit clinically meaningful, that's really important. So they're the differences that you actually perceive. They're the real differences, not just the number differences. So it elicited clinically meaningful differences in breathlessness, improvements in functional capacity, and improvements in quality of life. Now, there are a huge range of different ways that you can do respiratory muscle training. There's a huge number of different devices and different programs in terms of intensity, duration, the type of breath in or out that you're doing. In this study, we've been specifically interested in the inspiratory muscles, partly because there's more of them, and partly because they're the ones that are most likely to be associated with shortness of breath. And we've been really interested in what we call through range training. So that's training that doesn't just concentrate on beating a threshold. So you open up an aperture and then the rest of the breath is easy. This is a type of breathing that is effective throughout the entire breath in. So you're training every one of the muscles and not just. What I have now is a little video to show you a typical breath in that's part of this training regime, nicely modelled by our research assistant on the project, Dr. James Shelley. So I'll just play this.
Ready to inspire.
So as you can see, that really big breath in to start off with, nice peak at the start, and then he's having to sustain that breath for as long as he possibly can and keep the pressure up as it slowly falls off to the bottom right-hand corner of this graph. And that's where the difference is. If
Begin recovery.
Respiratory muscle trainers, it would just be one short, sharp breath, which is not going to, we believe, be as effective as this much longer inspiratory duration training. And this is exactly the same device as we've previously used in patients with bronchiectasis. So one of our PhD students has recently defended her thesis to present this work, where she demonstrated significant gains made over an 8-week training program. And these gains were in physiological parameters, as you can see at the top here. So the bars at the bottom are the mean responses, and you can see each individual participant response on top of that. So you can see that for the vast majority of people, there was a positive response. It isn't skewed by just a couple of people. And we saw that in terms of that maximum pressure and the sustained pressure. And we saw it in both bronchiectasis and healthy people. But perhaps more important than these physiological changes is that these changes were also perceived by the patients or by the healthy participants. And you can see a few quotes at the bottom there to support that, with people reporting that they could walk up hills that they haven't been able to do previously, and that they were much faster at recovering from any given activity. So with all of these things behind it, we wanted to use inspiratory muscle training to help people with long COVID. And we were very fortunate that we managed to get some funding from the Welsh Government to allow us to pursue this research aim. So what we're doing in this study, we're recruiting 250 participants, and they're being randomized either to the control group or the intervention group. Those in the intervention group will then receive an 8-week intervention where they'll be provided with one of the devices you've just seen and asked to do their training 3 times a week at 80% of their maximal capacity. And that's 80% on any given day. So as I said, if you're having a good day or you're having a bad day, this type of training will adapt to ensure that you never overexert yourself. Those people who are randomized to the control group will have the opportunity to then transfer to the active intervention arm on completion of that 8-week follow-up. But we do need the control group so that we can demonstrate that these effects are due to the inspiratory muscle training and not just simply getting better as time passes. So we've seen this app already. The reason why we're specifically using this device is partly because of this through range training, as you can see. So all of this area in blue is all this person's effort. But the other reason that we're using it is that all of the participants' data is uploaded onto a secure cloud server where we can then access it and provide feedback to participants. So we can track training, and again, we can see which people actually do adhere to the training, which is really important. We'll pull out at the end, does the training work, or does it work but people don't want to do it? These are all really important things if we're going to be able to make this something that works in the long run for the people across the globe who are suffering from long COVID. Now, as you can imagine, in the current world, this study is being done entirely remotely. So we're spending lots of time on Zoom, having wonderful conversations with people, if only we could meet them. But it does mean that it's also open to anyone across the entire of the UK. And via these Zoom sessions, we're assessing a number of different outcomes. So most importantly, we're assessing breathlessness. We're also taking measures of perceived competence and health-related quality of life via questionnaires. We're getting indicators of people's habitual physical activity, so how active they are, using activity trackers, sort of akin to your Fitbit, if you like. We're getting estimated functional capacity through a step test, which everybody loves doing. And finally, we are also taking or gaining insights into people's experiences of long COVID, but also their experiences of the intervention itself. So we're asking people what they liked, what they didn't like, what they found effective, because all of these views are going to be really important to allow us to modify and to refine this intervention so that it can be rolled out on a larger scale if and or when shown to be effective. So that's enough of the background and the study design. Now we'll get to the bit that everybody's really interested in, which is the results of the study. So before I reveal any of them, I just want to stress that this is preliminary data. So this is data on a small subset of our overall sample who have already completed the intervention. So these aren't necessarily going to be the final outcomes, but they are on a large enough sample that they are hopefully indicative of what their final outcomes will be. So first of all, in terms of our primary outcome, that shortness of breath that we were aiming to resolve, what we've seen in participants who have completed this to date is that this 8-week, 3 times a week intervention has reduced breathlessness by 26%. And that's what we call a clinically meaningful difference. And it's not just clinically meaningful, it's nearly 2 times the level required to be associated with clinical meaningfulness. So that means these changes are going to be perceived by the participants. These are big, these are much greater than you would typically see with pulmonary rehabilitation, for example. So we're really pleased to see this decrease in breathlessness, and this is feeding through into increases in respiratory muscle strength across the board. So we've seen a 37% increase in your maximum pressure that you generate during that first couple of seconds of this inspiratory effort. We've seen a nearly 30% increase in your resistance to fatigue. So this is how long your respiratory muscles are able to maintain that effort for. So a nearly 28% increase in that. And then we've also seen a 25% increase in your overall power of your respiratory system. So these are all really great changes. These all indicate that there's physiological effects of this training occurring, and they appear to be feeding through into perceived benefits in terms of breathlessness, but also in seeing people's perception of how much they can engage in activity or in exercise increase over this 8-week period. So this is people's belief that they can exercise. So if we can get people to feel like they are able to exercise again, once the intervention ends, they'll then be in a place where they can take control of their own activity going forwards. And we have seen that this also translates to increases in how active people are, so how much they're doing around the home. We haven't seen any differences in terms of the amount people are sitting down or lying down, which is sedentary time. And we haven't seen any great changes in terms of light physical activity. So that's the emptying the dishwasher or the walking slowly up the stairs. But what we have seen, which is really positive, is we've seen a 5% increase in the time spent in moderate to vigorous physical activity. Now that might not sound like a lot, but it does actually translate to a significant contribution to meeting those overall physical activity guidelines that we hear so much about in the news. Before I go on to talk about those government guidelines, what I also want to highlight is that not only is the overall time spent in this yellow orangey zone increasing, but the average location within this zone has also increased. So instead of being perhaps just over the boundary from light intensity physical activity, people are moving up towards the right-hand side of this arrow. So they're doing this activity at a higher intensity, and it's those higher intensities that we know are associated with greater health benefits. So this is great news for people's health. And as I say, 5% might not sound like a lot. It's 4 or 5 minutes a day, but if you add that up across the week, that adds up to meeting nearly 20% more of the physical activity guidelines of 150 minutes a week. So this is quite a substantial gain. And just to reiterate, this is from training 3 times a week for around about somewhere between 10 to 30 minutes. So it's not a huge time commitment, and we're seeing these fantastic responses. And finally, this is then feeding through into people's estimated fitness, an increase in people's estimated fitness. And this is actually likely to be an underestimation. And I say that because this is pre-post data, but many people couldn't do the step test pre. So this is only data on people who were able to do a step test pre. So if you factor in those people who couldn't do it beforehand, but we could get a reading on after, it is going to be a greater gain for those people. We just can't present that data here. And you can see that this is also demonstrated in the graphs on the right-hand side. So if I can draw your attention to the top one, first of all, this is a graph showing the heart rate response to each of the 5 stages of this progressive test. So these 5 stages get harder. So as you would expect, the heart rate for each one is a little bit higher. But we've got the pre-intervention and the post-intervention heart rates. And what you can see is that for any given one of these submaximal stages, the heart rate is lower. And the same down here, which is the perceived exertion. So for a given amount of exercise, it's eliciting a lower heart rate and a lower perception of effort. On these last couple of stages, what we can see then is the perception of effort might be relatively similar, pre and post, but that's a similar perception of effort despite a higher heart rate post. So we're now seeing that people can achieve higher heart rates without it feeling that much harder than a much lower heart rate before they were engaged in this intervention. So again, these are all really positive findings, but they are preliminary findings. And these are also supported by people's anecdotal reports of how they're getting on. So you can see reports here about people who are able to do 2 or 3 times more activity or walk up hills that they couldn't do before. People feel like they can breathe deeper, their lung capacity is getting better. Some people say they don't necessarily feel that they've improved, but they definitely haven't got worse, which is still a positive in a condition where we're typically seeing ongoing symptoms that don't get better. So the next steps for this study are, first of all, to continue our recruitment to get to that 250 goal. So if there is anybody listening who would like to take part, please do drop me an email at the end of the presentation. My email address will be provided. Or if you know of anybody else who would like to take part, please do feel free to pass on the study details to them. And the reason we're doing this reason why we're trying to get to this 250 target is that we can provide the evidence base for the NHS to then be able to consider rolling this out as a rehabilitation strategy for people with long COVID. So those are our future directions. And then one final other area where we want to have an investigation is in terms of whether or not this method could also be effective at preventing COVID, reducing the severity of the experience of COVID. So if we can get more people who are at risk to complete pulmonary rehabilitation in the form of this inspiratory muscle training, can we make their outcome better? So can we reduce the chances of people getting long COVID effectively? And you can see two different potential outcomes here. We've got the red, where people don't get inspiratory muscle training, so a typical progression. This isn't specific to COVID, I should say. This is just a generic prehabilitation versus no habilitation diagram. So you can see typical progressions with stays in ICU. This is these longer hospital stays, worse outcomes. Perhaps if we could get this tool to as many people as possible, what we could do is mean that people don't have to go into hospital for as long, or perhaps don't even have to go into hospital at all, and therefore have a much better outcome in the long run. So this is a future area for us to look into. So that brings me on to the acknowledgements. Those of us that are here today are a very small percentage of a very large team who have all come together to allow us to investigate this question. So thank you to all of the others who have contributed to this, and also specifically to the research participants. We couldn't have got to this point without you, and we are massively thankful for all of your time and efforts in allowing us to get this data. So that brings me to the end of today's presentation. As I say, if you or anybody you know would like to take part, my email address is on the screen now. Please do feel to hand it around liberally, and I look forward to answering any questions, or Joe is here to answer the questions as well.
We've got a few questions in the Q&A. Are you going to chair those, Adam, or do you want me to?
That's right, yeah, we've got a few questions that have come in already. And likewise, if anyone in the audience would like to ask, now's the opportunity. Dr. McNary, there's a few questions that have come in, first of all, about getting involved as subjects within the scheme. What are your inclusion-exclusion criteria for the study?
Great to hear that people want to get involved. We have very minimal inclusion and exclusion criteria. So the only criteria is that you have had COVID. You don't need to have had a positive PCR test because they weren't available for so many people. So you need to have experienced COVID and still be experiencing ongoing symptoms associated especially with breathlessness. Only exclusion criteria are around mental capability to provide informed consent for the study, or any complications that might put you at risk from doing the kind of exercises involved. But if you get in touch with me, I can address that on a one-to-one basis.
Great. And what method have you taken so far to recruiting subjects for it?
We've tried to take as wide a approach as we can. So we've been putting tweets on Twitter, obviously. We've been recruiting through some of the long COVID support groups that are on Facebook. And we've been doing recruitment drives through our local networks, such as the university email addresses and friends and contacts in that form.
Okay, questions are rolling in now. So someone has asked, once the muscles are built up, would you have to continue with the exercises to retain the increased function?
Great question. So what we think is the case is that after you've done the 8 weeks, you can actually drop down to once a week, and that seems to be enough to maintain those benefits. We do need to do further work to see whether that's true in this specific condition. But in Jessica McCreary's PhD, that's what she showed in bronchiectasis patients.
Okay. And again, a question's come in. She was lucky to have taken part and found benefits through the scheme, but as she used the term, am I cured? Do you think people with COVID will need to continue with this breath training?
I'm not sure if I have the best answer for that one yet. I suspect there is going to be an importance to remain active. And I think very much what we see this as is a gateway to activity. So whether or not you need to specifically stay engaged in breathing training, I would suggest probably not. But when you finish the breathing training, I would suggest there's a need to then start engaging in more whole body exercises to ensure you don't lose those benefits.
Okay, again, comments come in, lots from the participants saying they've taken part in the trial and it's helped them greatly. Someone's asked, do you consider the greater respiratory capacity of athletes as presenting a greater risk of contracting COVID and long COVID effects?
I'm not aware of any evidence that suggests that the respiratory capacity is associated with it. Obviously, there's been a lot of debate around immune systems and the effect of exercise on immune systems, and whether or not that could be related with some of the high-level athletes contracting COVID. But as far as I'm aware, there's no good evidence to demonstrate that those with a greater respiratory capacity have any greater predisposition to experiencing COVID.
To come back to methodology, a question was asked, how are you measuring the concept of breathlessness, as it could be very subjective?
Yeah, that's definitely true. So we're measuring it using the King's Breath Interstitial Lung Disease questionnaire, which is a validated and reliable questionnaire commonly used in respiratory conditions to assess breathlessness, and has been shown to correlate very well with more objective measures. So, for example, measures of ventilation, when done in the lab, have been shown to correlate with these subjective indications.
And on that with breathlessness, questions being asked, do you think there's a link with breathlessness and brain fog? That's something that we've debated a lot. I think there is the potential for there to be, although I suspect it's not a direct relationship. So it might be that it does have an effect, but I don't think it's breathlessness leads to brain fog. I think it's one of those much more diffuse questions. I certainly wouldn't want to claim that we're going to resolve some of the brain fog issues through these breathing exercises, I'm afraid. But I think if we can help with the fatigue, then that potentially does contribute to brain fog as well. Another question has come in terms of when training stops. So is there any suggestion that once the inspiratory muscle training stops, symptoms would return? We haven't heard of any reports as of yet. I don't know if there's any participants on the call who would like to actually answer that question instead of me, but certainly we haven't had anybody let us know that they've had any resurgence of symptoms following the training. A question's come in as well in terms of longer term impacts. So hopefully you can expand after the question as well on your sort of, your objectives in terms of the long term. But one of the issues with pulmonary rehab is sustainable gains after 1 year. So have you taken that into account and to what extent? Can you repeat that? Sorry, my internet broke up just as you said that. Sorry, one of the issues with pulmonary rehab is sustainable gains after 1 year. So are you measuring longer term impact, and what are the plans longer term? Yeah, we haven't got plans at the moment to follow this up. It would be a very useful element to add to it if we could get the additional funding to ask people to come back many months down the line to see if they have still got significant benefits. I anticipate, though, that because this condition isn't similar to your conventional respiratory conditions, which people normally do pulmonary rehabilitation for, that hopefully there won't be any issues with regression further down the line. So with your conventional respiratory conditions, which are associated with progressive declines in function, which pulmonary rehab help to slow or to stop for a little while, then as soon as that pulmonary rehab is taken away, they will go back to that downward trajectory, unfortunately. But with this condition, what we very much hope is that once we can resolve the current symptoms, hopefully that's then resolved and they shouldn't then research. But this is very much me hypothesizing, and we don't yet have the data to support that. The questions that come in about dysfunctional breathing, so I'm going to marry them together. So first of all, has consideration already been paid about subjects already having a dysfunctional breathing pattern? And is it possible that long COVID sufferers could be suffering from this without being aware of it? Yeah, I think there definitely is an argument to be made that those who are experiencing some of the worst symptoms could have something that's predisposing them to it, and it could be some underlying previously undetected
weakness or dysregulation that wasn't an issue until there was this additional complication. We aren't assessing people's breathing beyond what we can do remotely. So we would love to be able to get people to come in to do electromyography on the respiratory muscles to be able to look at those recruitment patterns. But unfortunately, just with how everything is, we haven't been able to do that at the moment.
On that then, in terms of like other factors, has it been taken into account, and to what extent other factors that could have contributed to the results that are separate to the training programme? And is there anything that you've identified I could talk about now?
I think there is likely to be a number of other factors. So I'd love to say it is solely the inspiratory muscle training and it's the saviour for all. But obviously, as people do begin to feel a little bit better, be it time, be it the inspiratory muscle training, they are engaging in more activities, and those activities are likely to be also associated with significant benefits. So, for example, I know of a number of people that have taken up things like yoga, and that's been shown to be highly effective for them. Other people have just reported how they've been able to return to some of their pre-COVID exercise regimes. So I think there are a lot of factors that are contributing to this, and it's not just the inspiratory muscle training. But as I say, if we can use this as a gateway to enable people to engage in those activities, I still see that as a win, really.
Good. Questions coming again in terms of like other factors. Do you consider that there could be a link between fatigue and mitochondrial dysfunction? And do you think that a transition to anaerobic metabolism that's been observed in some could be linked to the breathlessness?
That's a hard question. Yes, I think theoretically, if people were having to rely on anaerobic pathways, then they would obviously experience significant fatigue, and that would also lead to the breathlessness. I don't think that anaerobic respiration in and of itself would lead to shortness of breath. So I think if there is a relationship to those two parameters, it's definitely via an intermediary, such as the effect on your actual activity levels and the energy reserves you have to maintain anaerobic exercise.
In the preliminary results so far, is there any great variations between different demographic groups?
We haven't got enough data yet to be able to answer that question. That's another reason why we're trying to get to the relatively high target of 250, is to allow us to try and pull out some of those differences potentially, especially through sex, because what we know is that respiratory conditions tend to affect females much more severely than they affect males. So we're very keen to be able to pursue that stream through this data as well. As I say, we just haven't got the depth of data yet to answer it.
To pull in Dr. Hudson, so Joanne, there's a lot of comments and questions come in terms of long term and what could be done beyond the training programme. Do you have any comments or any sort of challenges or barriers to that beyond the programme?
Yeah, I mean, I think this is, so Mel's already alluded to some of these, and partly why the training is being used in the way that it is, in the sense that it needs to be something that's sustainable. It's something that's controllable by individuals, and I think that's partly why we're looking at some of the psychological variables. So Mel's already mentioned perceived competence, and we know that that's a key influencing factor to maintaining behaviour and to maintaining behaviour change. So from a psychological perspective, it's really important that we are seeing these changes in these psychological variables, because it's something that we can start to look at to see whether or not this helps people to maintain that behaviour moving forwards. And some of the other variables that Mel's not mentioned yet are some of the other psychological outcomes, like, for example, health locus of control. And personal control over our treatment and our regulation of our health status. And so that's something else that we're measuring. And so what we're anticipating we'll see is that this muscular training will be helping people to develop sort of increased personal perceived control over their health. And that, again, sort of motivates people, but helps people to maintain that behavior change, because they feel like they can make some instrumental change. And And actually, that's really important from a psychological perspective, given that in some of the early interviews, one of the challenges that people had was really that sort of perceived level of lack of control and the unpredictability of long COVID and its longevity and sort of inconsistency. And so being able to give people some sort of perceived level of control is really important. Shall I make another comment, or?
I think it's a good time to bring in Professor Lewis. Professor Keir Lewis is Professor of Respiratory Medicine at Swans University and is consultant at Hywel Dda University Health Board. Thanks for joining us, Keir. And I was just wondering if you could add any comments from a clinician's perspective based on the findings to date.
I totally agree. From a chronic lung conditions perspective, we've been doing a lot of pulmonary rehabilitation, and we know it really does work. And for Mel and the team to be applying this directly to COVID is almost becoming vital for us. I can only echo her comments that the NHS currently is literally on its knees. We're still dealing with COVID here in Prince Philip, and as a COVID lead here, I know there is no long COVID service that each of the health boards is trying to commission. And we're trying to learn more about this condition. There are apps that we're building with Welsh Government to help personalised treatment, but there's no strict intervention like Mel is planning. And the more we do this, we are going to be rolling out like a pyramidal structure where people can contact their GPs or physiotherapy and occupational therapists first, and then do this home training, and then perhaps if they're still struggling or deteriorating or breathless after that, then see a designated professional. But this home bit is going to come, it's going to work, and that will deal with the majority of people who are waiting to see us to have other deep scans. And I know that even acute COVID, and I put a comment in the Q&A, that we were exercising people on our ventilation unit as they couldn't walk. They were on high flow oxygen, but they could still do the arm strengthening exercises. And the videos on Twitter, we've had 20,000 likes at the moment because it shows people controlling their own destiny. It does really work, and we do this with other lung conditions when they're acutely in hospital. But long term, there is no sustainable joined up service. So we are going to be looking to do it direct to people's houses with that self-mastery and for people to engage. And I think it's working in other conditions, and it's going to work in this condition.
Good. That actually answers a question that came in right at the start. In lieu of long COVID clinics, the alternative pathways that could happen in Wales to deal with that.
I mean, in England, they gave £10 million to long COVID clinics, the 45 clinics, and in Wales there are, I think, is one clinic being set up. But the problem with these clinics is we don't even know what the main symptoms are to design what's the best input for that. So there is a long COVID tracker that we're pushing out through for people to measure their own symptoms. And ideally, if we can link this to Mel's project, they can follow their symptoms over time anonymously and incorporate this directly into GP records is going to be the plan. And that's a free access COVID tracker. But it has to be connected to an intervention so people can see themselves getting better.
In terms of the seriousness of condition suffered, and the question came in, if someone has had COVID pneumonia, for example, how effective are these techniques for those with extreme lung damage?
The ones I've seen, and the first 350 people that we've put through and discharged and followed up, only 2 people have had long-term scarred lungs. The vast majority of people with severe COVID in hospitals have horrible x-rays when they come in, but vast majority make a very good recovery on the lung x-rays and the tests, but yet they're still very breathless. So there's something else going on which we don't measure with traditional lung tests. And I think, as Mel was saying, there's muscle fatigue and the muscle breathing, and probably a bit of respiratory control, it's dysfunctional breathing. And if you look, for example, the part of the brain that controls breathing is very close to the part of the brain where the smell and taste nerves come out of. And maybe some central control of respiratory drivers making people feel so breathless, even when the x-ray looks like it's returned to normal. And therefore, the only way of dealing with that is through muscle training and confidence building, rather than drugs or other things that we've tried.
Cool. One for you, Melita. We've had a number of, again, comments and questions coming in about obviously being involved with the study, but if they can't be a part of the study, or if they know people who would benefit from this who aren't a part of it, how can they go about, getting the benefits from it, either with the equipment or without, what could be done as an alternative?
Well, the most popular one that I've been hearing about is obviously yoga and some of the breathing exercises that go with that. I think any kind of exercise which gets you to concentrate on that breathing will help. I think the specific benefits associated with doing some kind of inspiratory or respiratory muscle training type intervention is the additional load. So those yoga, I don't quite know what the right word is, postures, positions, you can tell I don't do yoga, they will help, they will be a starting point, but to really help with that shortness of breath, I think you do need to be loading and training those muscles like you would with any other injured muscle. So looking into getting an inspiratory muscle trainer would be highly beneficial. As I say, if people do want to take part in our trial, we do have spaces left and we will be providing the devices to people. So please do get in touch with me.
Some patients are telling me anecdotally things like learn to play a musical instrument. I'm a fan of the tenor saxophone, but things like where you're breathing continually and concentrating, it's a distraction as well for any neurological, it's a stress reliever. You might annoy the rest of your family, I'm sure, but a wind instrument, things like that, didgeridoo, some patients told me they picked up, but it's that constant blowing when you're feeling breathless and knowing that you're going to get through it. And the oxygen levels are always going to be fine. They were very low oxygen levels in hospital. The vast majority of people full recovery, but yet they're still disabled.
Dr. Hudson, do you have anything to add on that? In terms of what could be done in lieu of this prescribed training program and sort of alternative activity?
Nothing really. I don't think, Adam. Mel's, in terms of the interviews, those are the key things that Mel's been identifying. Yoga, but setting small goals and sort of readjusting sort of our kind of base, our expectations is really important from a psychological perspective to be able to build up that efficacy and that confidence that we can do things.
It's a question that's coming for you, Professor Lewis. Have the people that have demonstrated breathlessness without visible lung damage been on mechanical respiration?
So the patients I've seen tend to be the ones who've been admitted to hospital. I've had 4 or 5 people referred to me who've not been admitted to hospital, and they've got equally as bad breathlessness. It's interesting to see how disabled people are. So the admission to hospital does not really appear to predict the severity of long COVID symptoms, and that's been shown across Europe. What we're doing in the clinics, as I said, is have this sort of hierarchical approach. If the X-ray is okay and your blowing tests are okay, we then consider a heart scan, but only after you've gone through these other occupational therapy routes, and particularly exercise regime routes. 3 people I know have been sent home with oxygen because their oxygen levels have been very low, and all 3 have come off oxygen entirely since discharge. So we're not seeing the same amount of long-term lung damage as we feared. That's my early thinking. But there are other national studies ongoing, looking at long-term lung function, breath tests, muscle tests, in around 10,000 patients around the UK that we're participating in as well. And you can do that study as well as doing Melita's study.
There's a good question. There's a good question that's come in actually. Have you met anyone yet who could be considered fully recovered from long COVID? And I'd add to that, how would you define fully recovered?
I'd like to think I fully recovered. I had it, and I went from 2 weeks with 4 days where I couldn't walk down the stairs. My wife was insisting I go into hospital. I didn't want to go in. I was the worst, typical doctors. But I've got a slight loss of taste or smell at the moment, but that's it. In terms of walking and running and going back, I did. I would say, as you say, at least 1 in 5 have got long-term symptoms, but that means
I think we've lost Professor Lewis there. Is he frozen? Looks like it. It's a stormy day here in southwest Wales. Wi-Fi's knocking out all over the place. Hopefully he'll come back. In the meantime, Dr. McNary, is there anything? I think he might be here. Are you right back here? Good. I was just saying it's a stormy day here and Wi-Fi is intermittent.
Yeah, no, I said the majority of people have recovered, but we need to know more. What is it about those people? And I could see some of the comments there that maybe it is a neurological control or muscle control rather than physical lung damage. And I think it's something else to do with the breathlessness that these kind of studies would really, really help.
Questions come in. A symptom tracker was mentioned by you, Professor Lewis. Is there an app available to download and start using already, or is there work to be done around this and in a uniformed way?
Yeah, there is. The app is out, and I can send it possibly to you or Melita to try. We've beta tested it in the first 50 patients, and it's not very pretty at the moment, but it's there. And you can track your symptoms. So maybe if you feel breathless, but maybe less breathless over time, it can be reassuring. And if I can only see 4 patients a week in my clinics at the moment, which 4 do I pick? And how do I prioritize? So we need some sort of long-term management of showing people over time. And the other advantage with a tracker is that you can show, for example, a summary of all your symptoms to your GP or your nurse to see over time. And that would help us design our future clinics as well, because it has to be responsive to the patient's needs, not what we think.
We've had a couple of questions come in. I can see a hand raised. I think wants to ask a question live. So Pauline, is there a question that you want to ask?
You might be on mute, Pauline.
Hello?
Pauline, do you have a question?
Oh, I did. I think it's already been asked. I was going to ask what happens at the end of I'm sort of halfway through the training, and I just wondered what happens at the end if, you can, I have looked online, you can buy these devices, can't you? And then carry on, you say once a week would help, would it?
You going to pick that, Mel?
Hi, Pauline. Yes, we believe that once a week is what's required to maintain those benefits. Obviously, if you're doing it and you've got the feedback on the app, you'll be able to some extent see whether or not once a week is enough for you. But certainly with other respiratory conditions, that's what we've seen.
Okay, and at the moment, I haven't noticed so much. I mean, I've only done 3 and a bit weeks. I haven't noticed a big change, but I guess you've got to be patient and wait for the full 8 weeks to notice the difference.
Yeah, I think people are seeing benefits at different stages. So some people see them very early on, but others aren't seeing them until much later on. That's the joy of any exercise program. I'm afraid some people see rapid gains and others take a little bit longer to get to that point. So don't despair. Keep on going at it, and hopefully it will work for you like it has for some of the others.
Okay, thank you very much.
Thank you.
I agree with that. I think typically for pulmonary rehabilitation, it takes 8 weeks, 6 to 8 weeks for the benefits to really kick in. So keep going.
Good. Someone's picked up on a comment you said, Professor Lewis, that the smell and taste areas in the ear where breathing is controlled in the brain. Could that struggling to breathe cause neurological effects that may have long-term effects on either breathing or smell or taste separately?
No evidence it does, no. It's just there's a similar part of the brain that controls both. And I wonder whether it's that control of breathing can affect the sensation of breathlessness as much as any physical lung damage. Because I'm certainly seeing breathless people, and yet the x-rays have made a full recovery and the scans have shown no underlying clots or scar tissue, anything else that we look for in other lung diseases. Deep breathing will help both, undoubtedly. So the exercise will not cause any harm.
You all have mentioned actually, self-management and control in different contexts. And the questions come in, a key component, of course, of pulmonary rehabilitation is the education around self-management. Do you think there would be additional benefits if that could be incorporated in some way? And I'd add, how can we educate? This is a good example here this evening, but how could we educate the masses around this?
I don't know, Melita, want to take that? With pulmonary rehab, we've got a lot more evidence about what we're dealing with and longer term damage or physiology. We're still learning with COVID, but what we have done, we've made a series of patient videos with a Swansea company, and they're telling their own stories from going home. For the latest one was a lady who spent 28 days on a ventilator and something called ECMO, where blood was actually passed outside the body and back to her in London, and that's an unheard of story. 44-year-old, and what a wonderful lady she was and is, and learning from people who've been through it, I think, is going to be more powerful than experts, so-called experts like us, talking about it. And that can be done at scale. It can be done through digital and virtual media, and it will be incorporated, and is probably going to be put into the tracker, but hopefully we have got plans for that. And patient stories is all we have at the moment.
Dr. Hudson, do you want to add to that?
Well, yeah, no, I was just going to add that I think some sort of behaviour change techniques and self-management strategies could be built into any kind of like training app as well. And Mel talked about the feedback. That's part of self-management and building up people's sort of confidence and motivation to continue. I know Mel's done a little bit of that with some of the previous work that she talked about.
I think as much as anything, education is absolutely vital, but it's also getting some good news stories out to counter the so many horrific stories we hear on the news all the time. I think if we can start to get some of these messages out that there are ways that you can get better, then that can only ever end well, as far as I'm concerned. So I'm very keen that we try and advertise things that work and try and stop a little bit of the scaremongering, perhaps.
There's a lot of misinformation out there, isn't there? And we all know about false news, etc., fake news, but people like bad stories and dramatic stuff. They don't like good news stories as much. So you need to promote the successes. And people are recovering. They're recovering slowly, but they are recovering.
And I'm conscious of time. I want to finish on a really positive comment that came in as well. So Rose wanted to say that she's so glad that she joined the study. It was really satisfying to see my stats improve and know that I've done what I can do to improve my lung function post-COVID. Excellent work and brilliant webinar. And that's fantastic to hear. And I agree, that was really, really good webinar. Thank you to you, Professor Lewis, Dr. Hudson and Dr. McNary. Melita, is there anything you want to comment before we finish?
Not especially. I'd just like to say to anyone who has taken part, thank you so much again. And to anyone who is interested, please do get in touch. The more we can recruit people to this study, the stronger the evidence we can provide to the powers that be that will make the decision as to whether or not this makes it into a pulmonary rehabilitation strategy for the wider community. So a little bit of help from everybody now could make a massive difference for the wider group. So thank you, and I look forward to talking to many of you in the future.
Thank you for joining us, everyone. And thank you, Professor Lewis, Dr. McNary, Dr. Hudson, for your time this evening to inform and educate and inspire, but also the work you're doing day to day as well.